Okay, in part two, we're going to talk a bit about spirometry and PFTs. I'm not going to address every slide and every sentence, but we'll talk about the major ideas. So, spirometry is a tool that allows to measure airflow and volumes. That's very important because it can show a lot of and give us a lot of information about the system. Um, Basically, we're talking about pulmonary volumes, and we're able to conclude as to functional aspects and abilities of someone's system. So basically, what we want to find is either a functional problem or a structural problem in the sense that is something concluded or not, occluded or not. We can use this, of course, for performance. We can use it for health issues, meaning clinical populations, and so on and so forth. Um, Basically, the idea is very simple. You have a sensor. In the past, it would be a marker that would write down on a page. Today, it's, of course, digital. And changes in volumes that are inhaled and exhaled allow us to understand the range and span of the respiratory system. Let's see. Let's advance. Okay, so what we're using is a Gaussian curve, whereas 2 standard deviation from the average um, is still within normal population, and that's kind of a basic tool used, or a basic definition used in statistics. Um, okay, so when do we avoid PFTs being done? Obviously, you're not the technician, and you're not the one that is necessarily going to do it, although there are gas exchange analysis systems that are able to do PFTs. We can do it, for instance. So you can definitely do it in an exercise lab if needed. But usually, if you think that someone has a severe problem, you should refer them to a therapist. So, for instance, if we have hemoptysis with an unknown origin, if we have pneumothorax, unstable cardiovascular status like angina or recent MI, thoracis or abdominal or cerebral aneurysms, cataracts or recent eye surgery because of the pressure of, of blowing out air or exhaling, for instance. Recent thoracis or abdominal surgery, nausea, vomiting, or acute illness, and recent or current viral infection. So we're talking about total lung capacity, for instance. We can take it to the functional level and understand the functional implications of TLC. And we can, of course, look at it at the level of the volume itself. Same thing when we look at pulmonary function, for instance. We want to understand the mechanical aspects of pulmonary function. So that would be, the ability to produce high volumes within the system, and also the tension that is produced. So both of those would be indicators of pulmonary function. On the other hand, working against the system is the resistance to function. So that would be dependent upon the diameter and the content of of um, of what's going through the system, and we'll elaborate about that. Usually, when you see a PFT report, you have 3 major variables that are given to you. the actual result, meaning what you were able to perform, the predicted performance, what was, what did the machine think you should be able to do. And this, of course, uses formulas, amongst others, the principles that we've used before and talked before again and again about the size of the mammal and volume. And then it gives you, the percentage of the predicted. Were you above or on the mark or beneath? The predicted obviously, gives you some kind of reference to where do we want the person to be, and what should be normal for that person. So you have an example in the next slide, and then we start going over. We'll start going over these tables with these volumes. Okay, some of them are simply volumes, and some are actually functional, meaning that we can interpret them in a more functional way. So the first one that you've actually already studied is what is called tidal volume. Tidal volume, TV, or it's sometimes symbolized as VT, and that is, of course, the amount of air that enters the lungs during one cycle of inhalation, and we already know that it's about half a liter. Just remember that from this half liter, you have to deduct any dead spaces that we've learned about. Then we have IRV, inspiratory reserve volume, which is the air volume that can be inhaled at the end of a normal inhalation. So we know that a normal inhalation involves certain abilities, and then you can forcefully or actively inhale even more. On a regular basis, you don't have to do that. In other situations, you might have to force in more volume of air than possible, and we can see that we can enforce or force in about 2 liters to 2.3 liters more. So a normal inhalation, as you would do anyhow, and then you force in as much as possible. So at the end of a normal inhalation, you utilize the system's ability to increase the volume of air that is going into your lungs. And then we have expiratory reserve volume, which is the volume of air that can be exhaled at the end of a normal exhalation. And we can see that that is about 1 to 1.2 liters, meaning that we can inhale way more than we can force outwards. In other words, we're better in making room or space in the body than lowering it. Then we have the residual volume, the RV. That is the volume of air that stays in the lungs after a maximal exhalation. Just remember one thing, usually you're not able to exhale 100%. We see that the same idea in the heart with stroke volume, or what we call EF, ejection fraction. It's never 100%, and there's always something left inside of the system because of all kinds of reasons. Naturally, your mind should wander to either anatomical or physiological reasons, and we can see that it's about 1.2 liters. Now, if you look at this mathematically, you can see that the IRV, if you take off the ERV, you get the RV. So that's pretty simple. It's kind of mathematical in a way. Okay, functional. In the functional volumes that we have, you can definitely see the different ranges of functional abilities, and these will definitely affect someone's performance, for instance. So we have TLC, total lung capacity, the maximal volume in the lungs at the end of a maximal inhalation, meaning maximal volume that you can take in. We can see that it can be up to 6 liters, okay, at one time. Don't be confused with minute ventilation. Okay, once again, This is not minute ventilation. Then we have the vital capacity, which is the maximal volume exhaled at the end of a maximal inhalation. So you take in as much air as you can, and then you try to exhale as much as you can. So what you're seeing is the full range, extent of the lungs, taking in maximal air and exhaling, maximal air, and you can see that it goes up to 4.5 liters, meaning that it is less than TLC, and air is always kept in the system. Then we have the inspiratory capacity, maximum volume inhale at the end of a normal exhalation, meaning that you took the system to maximal active exhalation, and now you want to use a recoil to bring in the air back, and you can see that that's about up to 3.5 liters of air per trial, right? And then we have FRC, functional residual capacity, which is the volume left in the lungs at the end of a normal exhalation, and that should bring you up to about those 6 liters at max, which is your TLC, and that's about 2.4 liters. You can see the playing a bit between an untrained person and a well aerobically trained person. Obviously they all have the same amount of variables, but their size differs, and of course we are expecting numbers to be a bit higher when you compare a well aerobically trained person. So you can see from this schematic that TLC is bigger, VC is way bigger, RV increases, ERV increases, IRV increases, FRC is give or take the same. So and you can also see the mathematical equations between the two in volumes. Alright, you see the changes to the volumes and capacities during exercise in comparison to rest. So the numbers at rest are not really new. And we can see that we don't have one trend for all of the volumes, rather than some going up, some going down, and some will not change. For instance, we can see that RV does not change. We can see profound increases or profound decreases versus slight decreases. The next slide compares the volumes in men versus women, or women versus men in liters, and then on the right side of the table you can see the percentage of women compared to men. Okay, so if they're equal, it's going to be 100% because it's the same. But in the majority of the volumes, as we have talked about, once again, this is exactly what we're talking about, in mammals, about the size and the capacities of the systems. You can see that women, in average, this is important to emphasize, in average, are smaller than men. Okay. Notice that this is in regards to capacities. It does not talk about efficiency. All right, so don't be confused with that. And you can see, for instance, that the lowest number is ERV, where women have only 58% of what men are able to produce. Okay, so in every system, and we're talking about the pulmonary system, but this is true for every system, the outcome, the functional outcome, is the balance between forces that are what I call driving forces, meaning pro forces helping the system to achieve its goals, versus the balance with the resistance, basically, which are forces that are resisting or decreasing the outcome of the system. So we can see three balances here, which are completely logical. If you have, peripheral resistance versus lung elasticity, which is a major driving force, when they're the same, basically you have no airflow. And that, of course, means that you're dead and you're suffocating. We don't want that. When the driving forces with the elasticity of the lungs being the major force is greater than the peripheral resistance, then of course air flows through the system, and that's exactly what we need to happen. And of course the third option is that resistance is greater than elasticity, and of course you're dead. I've kind of said that in a nonchalant way, that you're dead, right? Just killing students here right and left. Okay, when we want to measure the mechanical aspects of the lungs, we have a few more variables that we can use to understand what's going on, and these are definitely terms that you might see in a printout of results of spirometry or PFT. So the first one is forced expiratory volume 1, or for short FEV1. That's the maximal exhalation after maximal inhalation during 1 second. So you want to take the system, and before I explain the table, I want you to try it. Try it at home, even if it's not with a machine, even if you are not getting the volumes on a screen. But try it with yourself so you understand what you're doing to your system. In this case, you want within 1 second, you want the system to go from maximum inhalation to maximum exhalation. And that is definitely taking the system from one end to the other within 1 second, meaning that you are at about 60 breaths maximal breaths per minute, which is a very high rate if you think about it. Okay, and you're taking the system really to its endpoints. Then you have maximal, what we call mid expiratory flow, MEF, meaning maximal airflow rate at the middle of exhalation. Why are we taking the mid-range? Because you want that's the point where you can see maximum rate. The rate of airflow is not the same throughout the system when you look at the whole span of the process, and that's a good point to see or to predict the overall total of airflow. Forced expiratory flow, what we call FEV 25 to 75. You'll find a lot of numbers, different numbers. You can check the FEV at 30%, you can check it at 10%, but when you take the 25th percent of the process to the 75th, what you're seeing is the half right in the middle. So you're taking off 25% here, you're taking off 25% here, and you get that 50% in the middle. Okay, and you want to see how airflow goes in there, and we'll talk about what we can understand from each and every one of these variables. We have peak expiratory flow, meaning maximal flow obtained during exhalation. Notice, once again, we're talking about flow, so that's volume per time. We're not talking about maximal capacity. Those are two different things. The next thing is maximal voluntary ventilation, MVV. What we want to see is the maximal VE, minute ventilation basically, or maximal lung capacity during 15 seconds. Okay. Then we have FVC, forced vital capacity, the maximum volume of forcibly exhaled air, it should be here, at the end of a maximal inhalation. So you're taking in maximal air into your lungs and then forcing as much air going out, and obviously it's not going to be 100% of what you inhaled. A bit more variables that are becoming a bit more diagnostic, so to speak. So we have what we call FEV1 to FVC ratio, or it's called FEV1%. And you use that as an index because you want to see what percent of the air you're able to play with or mobilize, right? Then you have what we call diffusing capacity. The amount, actually, percentage in a way, if you want to calculate it as a percent even, of the carbon oxide that you take in within during an inspiration of 10 seconds. And that, of course, shows your ability of diffusing small molecules. We have FIF, once again, 25 to 75. It's exactly like FEV, only that in this case we're talking about the ability to of inspiration. What else? We have static lung compliance. This is a very important aspect of lung function. When you want to understand the elasticity and the recoil of the lungs, this is definitely a major way to understand if there's any stiffness in the lungs, any problem within the tissue itself. So it's the slope that is representing the curve created by changes in volumes of transpulmonary pressures. And this is very, very important because it pertains to the compliance of the lungs. And as we are going to learn, the compliance of the lungs is extremely important. By the way, those of you who have taken pathophys already, we've talked about that. We've talked about the compliance of the lungs. And those of you that have not, will take pathophys and learn about it. The time for expiration is important. It can show, functional problems and the ability that the lack of ability or the existence of ability to exhale air volumes. And of course, when you're exercising, time between one end of the process to the other is shortened, so you definitely want to make sure that you're able to function within a normal range. We also have slow vital capacity, which is the maximum volume exhaled slowly after maximal slow inhalation. So that's not something that is phasic, that happens really fast from inhalation to exhalation, during exercise, for instance, or some kind of unusual situation. This would be the same process from one end of the process to the other, but slowly. What happens when time is not an issue? Then we have maximal pressure, Pmax, which is the maximal pressure produced by the respiratory muscles. That is asymptomatic, meaning how much force can the respiratory muscles induce or produce to help the system. We know that when we inhale, we are producing a subpressure situation within the body, inducing a pressure gradient, whereas the pressure outside of the body in the environment is greater than within the body, and thus air or volumes will flow into the body. When we want to exhale, we need to flip that over, and we need to create higher pressure within the body relatively to the environment. Obviously, in this kind of a case, we definitely need the respiratory muscles help, and since it's a pressure gradient, this is exactly what Pmax is able to help us understand. We have the inspiratory pressure, meaning what is the pressure produced upon the body when we inhale. Obviously, you have volumes of air coming into the body, and that elevates the pressure. We have the mean transit time, meaning that we want to understand what is the average time, from one end of the process to the other. And when you have a printout or you have input from the spirometer, that would be basically the area beneath the curve. We have MIP or NIF, maximal inspiratory pressure or negative inspiratory force. In this case, we're looking at the ability to function at the maximal when you have an occluded airway. Why is this important? Because you want to know if someone can meet the minimum ability to function when their airways are occluded. We have the coefficient of retraction. Basically, what you want to see once again are the elastic characteristics of the lungs and how that affects resistance. And you'll also see a variable called Vmax 50%, which is half of Vc, which can be a predictor of functional ability. Okay, when we talk about pulmonary function, we want to address two different aspects of it. The first one originates from the trachea and the lungs' mechanical characteristics, and the second one addresses the respiratory muscles and the mechanical characteristics of the thorax. So those are two different ideas and combinations. When we want to understand what's going on in the trachea and the lungs mechanical characteristics, MMF and Vmax 50 are very good indicators of that. And when we want to look at the respiratory muscles and the thoracic mechanical characteristics, the whole area versus just the airways within, then PEF and FEV1 are better indicators for that. Okay. Basically, going through these variables are usually taught in a bachelor's degree. I hope you have been taught this before. If not, then we'll go over it, of course. And if you have any questions, just let me know. Vital capacity. Vital capacity is the volume of gas measured from a slow, complete expiration. Right? You're taking out all of the air after a maximal inspiration without any forced effort, meaning that you're using the natural abilities of the lungs. We can see that vital capacity basically, in this case, abbreviated as VC, would be within a few normal breaths, right? Which is indicated here in this schematic as VT, that's tidal volume. and suddenly you go to maximal inspiration. Um, just to explain the graph here, the graph shows the increase or decrease in the volumes of the lungs. So if you are inhaling, more air is going into the lungs, so the graph is going upwards. And when you're exhaling, the amount of volume of air in the lungs is going down, so the graph goes down. And so you can see that spike, okay, when you produce VC, and then it goes all the way down to what you have exhaled. And then you can go up again to normal VT. So we know that VT is about 500 milliliters, meaning half a liter. When we have valid VC measurements, we use IC and ERV to calculate, or RV and TLC. So you can see, if you look at the schematic on the right side of the slide, the next slide, you can see that there are different ways to calculate the volumes, and it's based on those ratios that we've talked about before. So for instance, you can see that total lung capacity equals IC plus FRC. And you can see that, for instance, if you go from left to right, you can see that in the third column, you see exactly that the total lung capacity, the whole height of the graph is made out of both of those. Or that you can see that RV equals FRC plus minus ERV. Okay, you can see that starting from the second column on the left, going to the right. So if you know those capacities, you can of course play with that and calculate. So basically, you have an equation with two components, and you need to know at least two to calculate the third. I think that's kind of basic, right, in mathematics. Okay, what can we understand from a decreased VC? Basically, what we can understand that there's a problem in the pleural tissue, in the lung tissue. So we can have lung CA. It can be because of pulmonary edema. One can have pneumonia, changes in the lung tissue itself. I see that everything here is appearing twice, so that is, of course, a mistake. I apologize for that. It's a mistake in the slide. You can have COPD, obstructive lung disease, respiratory depression, or neuromuscular disease, meaning that you have a problem with the ability to change the volumes of the lung. What we call pleural effusion, which would definitely influence the mechanical characteristics of the lungs. Pneumothorax. You can have a hernia, which will affect that. Or you may have an enlarged heart because, as we know, any mass that will resist the lungs' will to extend will decrease VC. Another origin of decreased VC could be, of course, originated in the diaphragm. The diaphragm is one of the major muscles helping with respiration in total. So that can be, for instance, pregnancy, right? And when a woman is pregnant, you have increasing volumes of fluids, and of course the fetus, everything is pushed aside and upwards and downwards, and that's going to affect the diaphragm's ability to contract, and of course that's going to influence VC and other pulmonary functions. Abdominal fluids for any reason. Obviously the abdominal fluids during pregnancy increase, and of course any other kind of mass that might influence the abdominal cavity, meaning tumors. Bottom line, if we look at the pathophysiological aspects of decreased VC or the significancy, we're talking about major limitations to chest wall movement. If you're limiting that, you're definitely limiting A, the volumes that you can produce, B, you're elevating the pressure. The pressure is also elevated on the nerves, which induce pain. Okay. When we're talking about an VC of less than 80% of the predicted value for that person, the first thought goes to some kind of obstruction in the system. So you can of course see in the schematic here the idea of the comparison between rest and inspiration and expiration, and you see that there's an obstruction in one of the airways, in this case a small airway just before the alveoli, and you can see that we have in this case 3 different levels of obstruction, whereas in the right hand side they're showing what happens if the whole airway, in this case the left side, is obstructed, and you have obviously decreased functional ability. Okay, you can see what happens to the volumes in comparison between normal, restrictive, and obstructive situations. Just remember that obstruction means that you have no airflow, where restriction means that either the airway itself is occluded, or for some reason the functional capacity is decreased, such as with changes to tissue or fluids and so on and so forth. Alright, continuing to FVC. Once again, the maximum volume of gas that can be expired when a patient exhales as forcefully and rapidly as possible after a maximal inspiration. In this case, it's done sitting or standing. Obviously, standing is easier than sitting. You have less mass being pushed towards your thorax. So, maximal inhalation and then maximal expiration. And you can see a schematic of what you would see in a spirometer. So you see a few normal breaths. In this case, they're going on a trio, so they're telling the person on the 3rd time to completely exhale, right? So expiration, inhalation, in this case, expiration is upwards, so it's the obvious of what we saw with TLC before, okay? And then the person inhales as maximal as possible, okay? You see it with the dotted line, and then exhales as much as possible. And at the end, when you see that plateau, that is where the system is calculating FVC. Once again, I just want you to see how it looks like and understand how it looks like. You're not going to be technicians, and that's not the point, but you need to understand the system and its ability to function. Once again, when you have obstruction diseases, FRC will even equal VC in healthy individuals, but you'll see it lower in patients with obstructive diseases. And the schematic is the same that we saw before. What might reduce FVC? So mucus, obviously. Mucus is a disturbance in the system that will interfere with normal flow and function. It also is very heavy, by the way. So if you take the relative weight of the mucus to the tissue around it or that organ or area of the body, it definitely elevates pressure and elevates resistance. Any bronchial narrowing, obviously, if this is your pipe and now this is your pipe, airflow is reduced. Chronic or acute asthma, of course. Bronchiostasis, going to affect the elasticity of the system and its ability to adjust to the volumes that are going through the system. Cystic fibrosis, of course, is going to affect the ability to function, obviously. And any other obstruction for any kind of reason. It can be scarring, it can be due to smoking, it can be an injury, something that you've swallowed, what we would call a foreign object in some cases. So, of course, any obstruction of one of the main stem bronchi will affect anything lower in the system, or what we call the lower respiratory tract. Okay, so we see that in normal populations, healthy populations, it will take us 4 to 6 seconds to exhale their FRC. When you have obstruction, when you have a functional problem, the duration to achieve the same capacity or functional result is lengthened, and you can see that it can be up to 3.5 to 5 times more, to about 20 seconds. Okay. I think I forgot to talk about the 15 seconds. So we can see that when exhalation times are more than 15 seconds in the previous slide, the decision, the clinical decision is kind of the same. Basically, what I'm saying is that 15 seconds and above is a clinical cut point for decisions. Within that, there's still room for reasoning and different kinds of decisions. When we're talking about restrictive lung diseases as opposed to obstructive, we see that FVC is decreased. We can see that due to pulmonary fibrosis, which could be the result of dusts or toxins, drugs, radiation therapy, or radiation in general. There's radiation also in the environment. Any congestion of pulmonary blood flow, such as in pneumonia or pulmonary hypertension. Any lesions that occupy space, tumors, pleural effusions, obviously any one of those masses that will take up space will affect the FVC as well. Any disorders to the respiratory muscles, any chest deformities that will affect the space and the structure. And of course, when we're talking about masses, anything that causes changes in mass, such as pregnancy or obesity. Remember that when we're talking about weights, we're talking about some kind of mass multiplied by gravity. You know, if you have a pound on your chest that is pushing down or pushing in, does it truly matter if it's a weight in the gym or fat or you know, some kind of volume and mass of fluids? At the end, you have a pound. Of course, the treatment might change and the diagnosis and prognosis might change, but at the end of the day, you have something resisting the functionality of the system. So that's where obesity and pregnancy comes to play. If you have a woman on her back or any person on their back, right, and they're obese or they're pregnant, you have all of that weight pressuring down on the tissues and organs that are beneath it. And obviously, if you're pushing down and you have systems, you have the circulation system, you know, arteries, veins that need to expand and something is pushing them down, you are elevating resistance. If the lungs have to expand and you're pushing down, you're elevating resistance. If you have the heart that wants to expand, right, to produce a better stroke volume, and you're pushing it, you're elevating resistance. So that anything that takes up space and prevents expansion, or that elevates the pressure and the weight and the resistance on the organs and tissues, is going to decrease functionality. By the way, in bodybuilders, you know, when they're lying on their back and they have huge pectoralis muscles, same thing, by the way. Don't think, you know, and they're active and they're fit and they look awesome, right, dude? But they're still working against their heart and lungs, in the sense that the muscle is a weight. Okay, we have, in this case, in the next slide, we're talking about forced expiratory volume, FEV1, which is an important variable of function. And you can see what happens to the volume with time. So FEV1 is at the first second, and FEV6 is after 6 seconds, so 5 seconds from the first one, and so on and so on. And you, of course, you know, let the person breathe, and then ask them, you know, to do that maneuver. Okay, what can we understand from a reduced FEV1? First of all, obstructive reasons or restrictive patterns. You have different patterns to if it's obstructive or restrictive. But remember that in this case, the patient's effort might influence the test. So motivation and understanding of the need to perform well, willing to take the system really to its edges, are very important in such testing. Exactly, for instance, you know, when someone is max testing on TM, they can stop after 5 minutes. What are you going to do? Nothing. But you understand that it's due to motivation, right? And that psychological aspect and that motivational aspect and that effort aspect of tests definitely can make a difference. So we want to make sure that they're pumped up, so to speak, and motivated, and they're really giving it their maximal effort, because we don't want a decreased FEV1 to be due to effort and we're going to analyze it clinically. That's not a good idea, right? So once again, we see the reasons why FEV1 can be decreased in obstructive diseases, and it's kind of repeating itself. So The only thing that in this case you can see um, two new aspects that we've kind of talked about before, but they're indicated here separately, is the narrowing of the airway during expiration or forced expiration, and you can see the bronchospasm. So anything that will cause a spasm obviously is going to affect things. Inflammation, of course. Inflammation, results usually in volumes of fluids, accumulation of fluids, and obstruction of flow because of taking care of the inflammation. You have the whole immune system responding as well. You might have a fever, so definitely you'll have dead tissue that has to be taken care of, so that's definitely going to influence. And as we said, any foreign body and tumors that are going to grow into that space are going to decrease the abilities. Okay, I'm going to stop here because we have a cap of an hour, and I'll upload another third part to this video. Stay tuned.